Welcome to the Critical Care Obstetrics podcast. My name is Suzanne McMurtry Baird. I'm the nursing director, and I'm here with my partner, Dr. Stephanie Martin, medical director at Clinical Concepts in Obstetrics. Today, we will be discussing cesarean delivery as major abdominal surgery. So before that, I just want to reintroduce Dolly. You can hear her in the background probably howling. She's growing up, and I tell you what, I can't keep up with her. She's already 60 pounds. But anyway, if you hear her, you know she's present as we record. But
she's learning all about C-sections.
She is. She's going to learn about C-sections today. And because of her heart issues, she won't ever have babies. So she's going to have to not be a mother. So she won't ever have major abdominal surgery. But
hopefully.
Anyway, I know, right? Okay, we're going to get back. Major abdominal surgery. That's what we want to talk about. You do realize, and we were just kind of talking about some of the statistics with C-sections, and we talk about C-sections being major abdominal surgery all the time because it is the most common surgical procedure that's performed in the hospital in the United States. And when you think about that, joint replacements and hysterectomies and gallbladder, liver, any other surgical procedure, trauma. I mean, this is the number one performed surgery in the United States. So that's insane to me.
Yeah, I mean, 1 in 3 women roughly are going to have a cesarean. So we're talking, well over 1 million cesareans a year happening in the U.S. And, we talk about this all the time, but people talk about C-section like it's, going to have, I don't know, like a nothing burger. Like it's no big deal at all. Everybody does it. You'll be fine. What's the big deal? But this is incredibly invasive. I mean, what other surgeries do we actually open the abdomen these days? I mean, hysterectomies are all done, with minimally invasive approaches, robotics. I mean, everything is done through this minimally invasive approach now. And C-sections, you got a 10-centimeter incision on your belly. There's very little stuff that's done this aggressively these days. Now, I don't know any other way to do it, but,
I know, right? But we've normalized that. I mean, you have these women that are having these C-sections, major abdominal surgeries, and within, 6 hours they're up, they're walking around, and here, take care of your baby too. And if it's at night, their support person may have gone home and they're in their room with this newborn. I mean, insane. And that may be after 2 days of labor or 3 days of labor.
Exactly. I mean, that's every woman's fear when we talk to them. It's like, I don't want to go through labor and then end up with a cesarean after that. And totally 100% get it. Like, surgery is hard when you're like in peak performance, peak state going into the procedure. But opening the abdomen is exhausting for the patient. It requires a lot of skill from the surgeon. And granted, we do these procedures all the time. It's something that OBs are very, very comfortable with, which is fantastic. But that doesn't negate the significance of the procedure that's being done.
Right.
I don't know I think I told you this story, but back in the day, once upon a time, I was part of an accreta program, and I was counseling a patient and her partner about the need for hysterectomy at the time of birth. She actually had a percreta. It was pretty extensive. And so it was very clear that hysterectomy was in her future. And we were talking through what that looked like and the plans. And the partner became very, very upset with me and really was challenging me and flat out told me that I was a terrible surgeon because I couldn't do this procedure laparoscopically. Folks, I don't know how anybody can deliver a baby laparoscopically. And I'm certainly not going to deliver the baby, close her back up, and then do it hysteroscopically. But yeah, it's just one of the few things where we actually open the belly and deliver the baby and do the surgery.
Well, and we've done so much work across the country to try to decrease the number of cesarean births that we're doing, and especially trying to avoid the first cesarean. And that even with those initiatives, I know individual hospitals or some states may have brought their numbers down some, but it's still, again, that 1/3 of all births are by cesarean delivery, and that's been pretty consistent for years now. I mean, certainly when I first started practicing, it wasn't that way. I mean, we had a high risk number of patients, but our cesarean birth rate was very low. So I think there's a lot of things that we could talk about as far as why that is. Avoiding that first cesarean, I know ACOG has an evidence based document out on cesarean section. So and lots, again, states have quality initiatives to decrease the rate. Things like not only that avoiding the first cesarean, but neuraxial anesthesia instead of general anesthesia, the use of antibiotics, the family friendly components of cesarean birth, utilizing clear drapes, having your support person with you, skin to skin after the cesarean birth. Some ORs, some facilities, that's been slower uptake than others because it requires additional nursing staff. There's been some pushback from some anesthesia providers as well. So there's lots of components that we could include in here that is evidence based as well as family friendly. But I would really want to spend time talking about why this is major abdominal surgery. So, Stephanie, take it.
Yeah, I mean, it's such a common procedure, and especially like the baby has to be born somehow. It's going to come one of two ways. And 1/3 of women it's going to come abdominally. The baby will be born abdominally. And the overwhelming majority of these surgeries are not by choice. They are indicated, necessary for either a fetal or maternal indication. So it feels like, well, we just got to deal with what we got to deal with, which is true. We're very good in healthcare at just saying, we got to figure it out and make it work. And that's great, except that we cannot we cannot normalize the fact that this is, because it's so common, it's no big deal. It really is a big deal. So the surgery itself, we're entering the abdomen. You're literally going into the abdomen. The intestines are there. The bladder sits directly on top of the uterus. We have to literally separate the bladder from the uterus in order to make a good incision. So you run the risks of injuring all of these organs because you're directly interacting with them. And sometimes that's very simple. If you have a patient who you can easily visualize everything, she doesn't have scarring, etc. And sometimes it's incredibly challenging.
Right.
Patients who have large abdomens or a big pannus that's very heavy, sometimes just the geography, the actual anatomy makes it extremely challenging to get into the abdomen and see what you need to see. You can have difficulty packing away the intestines. There might be scar tissue. It can be difficult to avoid the bladder, for example. And the blood vessel, the blood flow to the uterus at term is enormous. It's at least 500 cc's per minute. And those veins are as big around as your finger. They're enormous. Frankly, it's always impressed me how resilient those blood vessels are and how we're yanking around that uterus, we're moving it around, and they don't just lacerate. They hold together. And we get lucky a little bit, I think.
No. Yeah. I when I scrubbed scrubbed in on C-sections, which was, believe me, not my skill set, but I had to learn, and it was not something I did all the time. So I was like, okay, you're going to have to tell me what you need. But it was so impressive to see those veins and just how huge they were.
Yes.
Don't touch them.
Don't touch them. Well, yeah, when I was doing accreta surgeries, I would basically just jokingly tell the team that would be operating with me, don't even look at them.
I know. I was back there with you.
Don't touch it.
Back there with you.
Don't look at it.
Taking a picture one time. The patient had given us permission to do some pictures, and I took the picture of the blood vessels. I was like, oh, I don't want to look at that in the picture.
Very intimidating. Okay. And there's certain things that can make that we know going into the surgery that are going to make it higher risk. Multiple prior cesareans, patients that are obese, multiple gestations. Obviously, if they've got an invasive placentation like accreta or percreta, those type of things, or even a previa. All of those things we know are going to increase the risk, and we have to prepare for it. If you're not anticipating it, if you're just thinking we'll figure it out when we get in there, then you're just not prepared for the possibilities of what can happen. And then you're reacting to things instead of being proactive.
Right. No, you never want to do that. And you and I, having worked together on that placenta accreta program, we know the in-depth planning that you need to have for each patient, because each patient is different, and to what to anticipate and plan their care is so essential before you get in there. And imagine being in a hospital that you don't have the resources that we had, having a patient like that. No, no, please don't. That's why they don't recommend it, right?
Well, and that's why there's these guidelines, there's standard approaches. I think it's in what we call the Pink Journal, which is AJOG MFM. They have a whole multi-part series on evidence-based cesarean. I'll put a link in the show notes if you guys are interested in that. That kind of talks about what does the evidence show about all the different parts that go into performing a cesarean, like preoperative antibiotics and neuraxial anesthesia and how to close the incision, et cetera, et cetera. So there's a lot of information. There's a lot we still don't know, of course, but there's a lot of information in there that can help you understand what is the current guidelines, specifically if you have certain patients where you're wondering, or certain physicians, maybe you're wondering, why do they do it that way? That wasn't how they did it at my other facility. But there are some, one of the things I kind of wanted to highlight a little bit is a non-low transverse incision. So there is a reason why we do a fan and steel incision and a low transverse uterine incision. So the fan and steel incision is transverse on the lower abdomen, a couple of centimeters above the symphysis pubis in a patient with normal anatomic landmarks. What I mean by that is that as your patient's, the size of her abdomen or her pannus increases, you may not have normal landmarks to know exactly, to say, oh, it's going to be 2 finger breadths above or whatever it may be. It can be very, very distorted. And so you have to strategically plan where that incision is going to go. So in any event, you're going to do this fan and steel incision for the vast majority of patients. And part of the reason is if you think of something called Langer's lines, which is one of the principles in surgery where there are planes, or I don't know how best to describe this, essentially how the tissue is aligned on the abdomen, and in that lower abdomen, it's horizontal. And so when you make the incision horizontally, it's in parallel to those Langer's lines, which facilitates healing in a proper manner with minimal tension on the wound. So you have, the best opportunity for healing with the minimal scarring and minimal risk for infection in that manner for most patients. That's where that comes from. Sometimes we'll do a vertical incision, midline vertical. I did many of those back in the day, but they're less common. Overall, just by nature, you're going across Langer's lines and not parallel to them, so that the incision is going to be under more tension. You have increased risk of separation, infection, scarring. So it's not ideal. Plus, it's much more uncomfortable for the patients in general. And your anatomical landmarks are different. But the big advantage to a vertical incision is visibility. When you have a vertical incision, you can see what's in the abdomen and you can access the things you need to access. And that's one of the reasons why we choose that commonly for situations like maybe when we know we're going to need to do a hysterectomy for an accreta, or maybe if we know it's a uterine rupture, we might approach it in that manner. But really, we're going to be doing that when we know that we need to look in the abdomen and have access to the entire abdomen.
Right, right. And I know they're not that common. Is because of the healing, and this may be in my imagination, for example, like an obese patient, don't you move that incision up sometimes a little bit because of that?
Yeah, I think incision planning in the obese patient who has a pannus is particularly important, because if you do a fan and steel incision underneath the pannus directly above the symphysis, you could be putting that incision directly in a crease where it's moist, dark, warm, and you have a much increased risk of infection and scar and incision separation, wound separation. So sometimes we'll make the incision higher on the abdomen, but still have it transverse. That may mean now you're going through a very deep section of the abdomen, and you'll need longer instruments in order to be able to safely operate on the patient. Many situations, the pannus hangs low so that the umbilicus may be much lower anatomically and closer to over the symphysis itself. And in those situations, it may be safer and less deep in order to do a midline vertical incision above the umbilicus. I've done many of those, and that may be the safest situation. That's going to take some planning and some conversation with the team and the patient to set expectations for what's going to happen. But it can be very tricky. And, when you think about lifting up the pannus, if you're going to make it lower underneath it, well, now you've got the weight of that pannus on the patient's chest, which can make it very difficult to breathe and oxygenate and make her uncomfortable. And the anesthesiologist is then going to have to deal with that situation. So,
Yeah. Yeah, and I think that's something that's kind of evolved since I started practicing, because we would have a lot of wound infections in those patients, and you saw some tremendous, long extended hospitalization, and because of those infections and separation, wound separation, readmissions and stuff. So,
or they go home with a wound vac and delayed closure, and that's unpleasant for the patient. So, there are strategies that can be used to try and lower the risk of that happening, including additional layers of closure, et cetera. But one of the basic principles is to make sure that the patient herself is prepped adequately before the surgery, and you give antibiotics, you do the appropriate closures, but you want to make sure that your wound is in the most ideal location for the patient, where it's not under tension, and ideally not in a warm, moist, dark environment, which is going to facilitate infection and poor healing.
and I'm assuming that conversation would be happening outpatient, but then also communicate that to the OR team as well.
I think ideally, it's happening multiple times. Ideally, it's happening in the office, with the providers who are going to be taking care of the patient and doing the exams to determine. And then when she gets admitted for either labor or for the cesarean, another conversation in real time about where is the best incision location. But ideally, the patient isn't hearing this for the first time when she's in the pre-op area
Or
or
post-op.
or post-op. Exactly. That's not fair to her. So a lot of planning can be done ahead of time if you're thinking about these things. And many docs are. This is not an unusual situation for the patient, for the team to be in. So these conversations are happening commonly, but they need to be happening ideally before she's under anesthesia.
I had a question I saw on social media this week, and it was, do y'all allow who do y'all allow into the OR to go back with the patient? And thinking back on that family environment, and a lot of patients are hiring doulas these days, and which are great, but um, how does that play a role? I know hospitals will have a policy or, a practice that's identified as something like we allow one person if they have neuraxial anesthesia, but that's it, nobody there during general. Are you seeing anybody allow doulas come back as well as, let's say, the partner of the patient?
Yeah, I think this is a really interesting conversation because cesarean section is a major abdominal surgery, and there's really no other surgery where we allow family or support people to come back into the operating room. Nothing that I'm aware of where we bring family members back to the
Yeah.
operating room to be part of major surgery other than cesarean, which is completely understandable because this is more than just a surgery to the patient. This is a life-changing event, the birth of their child, which may be stressful and chaotic, and there may be grief involved, or it may be joyous and perfect and everything that they expect, and this full spectrum in between. So I think having support people be part of the process is very, very important. But it's another example of where we have normalized that this is not major abdominal surgery. So from my perspective, this is really about a safety issue,
Yeah.
balancing the needs of the patient and the family with safety. I think it's fantastic that we're seeing this transition to making cesareans more family friendly and making sure that we minimize the disruptions to bonding and early breastfeeding and all of those things that should happen in the golden hour, getting skin to skin. All of those things can still happen. But that means that everybody has to be motivated to make it happen. And frankly, most of the resistance to it is, from my perspective, either lack of understanding of the importance of that or lack of respect for it. But a lot of it is frankly logistics.
Yeah. Yeah, I've certainly been in ORs where you can't hardly walk, and or you've got cords everywhere and you don't want them to fall or, you know, have some type of fainting episode during the C-section and stuff. So I can see the safety from that. But then I've been in ORs too that may be able to handle that extra person. I don't know. I don't know anybody that's out there doing it in this, from my understanding, but I didn't know if you'd had like patients approach you about that or not.
Well, it's pretty standard to allow at least one support person
Right.
back into the operating room, but even that's a safety issue. Doesn't mean it can't be done safely, but it means the staff in the operating room are responsible for the safety of the patient having surgery and the safety of the support person in the operating room. And that could be they could fall and injure themselves, they could pass out. I've seen all of the above happen.
Right.
I've had family members try to interrupt a procedure. I've had family members try to, not intentionally, but they don't recognize that they could be contaminating a sterile field, et cetera. So you have to have somebody available to essentially babysit that person and make sure that the safety of the patient and the support person are prioritized. And the more people you have back there, the more resources you have to maintain safety. Doesn't mean it can't be done. It means it requires more resources. That's a challenge. It's a challenge to find resources just to staff the unit, much less make sure that people observing in an operating room are safe.
Right. You got one nurse for circulating and one nurse for the baby. And so
Yeah.
that's a lot. I know.
It
Well,
reminds me of that. You remember that Seinfeld episode where they get to go into the operating room theater, where this is one of the old fashioned theaters where they actually have like seats up and around and they're looking down, and Kramer drops a Skittle into the surgical field.
yeah, that's right. I remember. I went to, it was in Philadelphia at Jefferson. They had one of those old theaters. And so it was fascinating to see. So anyway,
Yeah.
okay, back to our major abdominal surgery discussion. Let's talk some of the complications because, again, I think because we've normalized C-section so much, I think sometimes we don't start thinking about this is, again, major and complications can occur. So the one that comes to mind besides hemorrhage,
Yeah.
obviously you lose more blood loss and you can have a higher risk of anemia, is venous thromboembolism. That these patients are 9 times not more likely to develop a clot, and that's big. And especially when we were in a time period where we were having more elective cesarean sections. I think that's not as common these days, but still done, I believe.
Well, you start
That
stacking on the risk factors.
right, stacking them on, right. So you have the obese patient that's had a C-section that's been in labor that is now infected, which is another complication, which is a higher likelihood of sepsis. And she's had more blood loss and she has anemia. And so you just start,
And
you
she's
know,
postpartum. So
and she's
postpartum
postpartum.
period is the greatest risk period for developing a clot, period. And then when you add surgery on top of it, and then if you add other things like obesity or tobacco use, the risks just start to escalate. So this is why we have the recommendation that every single person have perioperative prophylaxis, either mechanical or pharmacologic. So you can give them heparin, low molecular weight heparin, or you can use sequential compression devices. It doesn't matter. Do something. And what you do is going to be dictated by their degree of risk. And that's universal because it's very
Right,
common.
right. And little confusion still there with that, but
Mm.
everybody I think is pretty much doing at least SEDs. But think about damage to the organs. And uh, we're going to talk about PACU in a minute, which we're seeing more and more PACU complications. But damage to the organs is an issue. They're right there, like you said. I mean that, especially bladder, especially bowel, internal hemorrhage afterwards. And then you've got the risk of placenta accreta spectrum disorder. And you and I have seen some pretty large invasive placentas in our program that we help to develop. That's to me is so huge these days.
Yeah, I think you have to kind of think of it in terms of immediate
Yeah.
complications and then longer term complications. And
Yeah.
I think a lot of people focus only on the immediate. Are they bleeding? Did they develop an infection? And then let's not discount the anesthesia complications potential. And that's
Right.
one of the reasons for neuraxial anesthesia with very rare exceptions, because it's so much lower risk for mom and baby compared to general anesthesia. Now, both are safe because they're people are very good at giving anesthesia, whether it's neuraxial or general, but comparatively speaking, neuraxial is lower risk for the vast majority of patients.
Well, because of increased risk for aspiration.
Yes, and bleeding risk if you're under general anesthesia, the
Right.
baby will be born depressed because the baby will have the effects of the general anesthetic. That's transient, but your APGAR's not going to be 10 at 1 minute if you're under
Yeah.
general.
Baby's a little
Yeah.
sleepy.
But I wanted to comment about one thing that people may underappreciate. OBs and OB teams have a make it work kind of attitude, which I applaud in many, many ways. But because of that, sometimes we don't appreciate how significant what the scenario was that we just made work. And one of the things that comes to mind for me immediately is a non-low transverse uterine incision. So I was talking earlier about the fan and steel skin incision. There's also a reason we do a transverse incision on the uterus itself. And it's also because of how the muscle layers come together. So they kind of wrap around. So they wrap around, and then in the bottom of the uterus, they're parallel to each other. And so it's like, now I'm going to gross you out a little bit. Okay. So if you get gross, just plug, if things gross you out easily,
You're
just
talking to OB people.
plug your ears.
Come on, we can talk about this during the
I want you to think about a chicken tender. Okay. A chicken tender is a piece of muscle. It's this
Which
muscle that
kind?
came.
Can I stop right there?
Yeah.
Like McDonald's chicken tender or
um,
Chick-fil-A? Because there's a big difference.
I would say Chick-fil-A.
Okay. Okay. Good. Okay.
Definitely not Raising Cane's.
No. Okay. I'm sorry.
Yeah. So if you take that chicken tender and you pull it longwise, it's easily going to pull off into strings, like string cheese.
Right.
Okay. It pulls off into strips easily. That's what the lower uterine segment is like when you make the incision that long way. It's like you're cutting along the line that it naturally wants to tear on. If you go the opposite, it's like trying to rip a chicken tender apart crossways instead of long ways. It's very difficult to do, and that's because the way the muscle fibers grow. And that's the same thing in the lower uterine segment. So what you will see very often, we just make an incision and then we put our fingers in and then just pull it apart. And it just like that chicken tender pulling along that plane, that's exactly what happens on the uterus. So that also means that it heals better and therefore has a lower risk of rupture in future pregnancies. But sometimes we don't have the luxury of doing that incision. And there's a few scenarios where whether you're the OB or you're the nurse in the room, if it's not planned, sometimes it's planned. We're going to do a vertical or classical incision. Okay. We call it classical. But sometimes it has to be done and you don't know it. It's always going to be associated with increased risk for bleeding. So extremely premature. There is no lower uterine segment to cut into. It can be just a couple of centimeters wide. There's nothing there. So you're not going to be able to get a baby out that way. You have to go up and down. Babies that are not vertex, especially if they're transverse or sometimes breech, very difficult to get out. You can't get in the lower uterine segment. You have to go vertical. Sometimes we go transverse thinking it's going to work and it doesn't, and then we have to go vertical. And all of those scenarios mean bleeding immediately, increased risk of bleeding, and problems with healing and risk for future uterine ruptures. So this is the reason why we ask everybody, have you ever been told you can't have another labor? We want to look at operative reports as often as we can so that we can know what happened. But the big red flags are extremely premature birth, especially a premature non-vertex birth. I'm thinking non-low transverse incision. So you can anticipate risk of bleeding if you're in that scenario.
Right. Which brings us to the other thing that I really wanted to talk about, and that's PACU care.
Yeah.
Again, we've normalized that. We take this patient who's had major abdominal surgery back to her labor room. That would never happen from the main OR, can you imagine going from the main OR back to a general med surg unit to recover a patient? And I think pretty consistently, general anesthesia will go to a PACU area, but our patients who have neuraxial anesthesia will a lot of times go back to labor and delivery into their room and be recovered for those 1 to 2 hours, and usually 2 hours. Anyway, so we don't talk a lot about PACU care and the qualifications of PACU, the complications that we're seeing occur, which will be another podcast, and then the communication issues that we may have. And for example, you think the patient might be bleeding, and who do you call? You call OB? Do you call anesthesia? Do you call them both? Maybe you just have abnormal vital signs and you don't know why. So who do you call besides Ghostbusters? Communication. So lots of things like that occurring in the PACU as well.
I think people just in general underappreciate the risk of the major abdominal surgery that just took place, and therefore they minimize the risk in the immediate postpartum period. And this is when bad things happen. We're seeing it more and more. We're hearing it more and more. I think we just need to understand this is major abdominal surgery. It doesn't mean it can't be done well and safely, and it doesn't mean that it's not necessary much of the time. It means we need to be respectful of the risks, do what we can to minimize them, and be prepared to deal with complications should they occur, and that includes the PACU.
Right. And I wanted to point out that we do have a new postpartum course out.
Very exciting.
I know. And there are 2 lectures in there that are brand new also. And one is on PACU care, and another one is on enhanced recovery after cesarean. And we based that on a new document and recommendations of evidence-based practice for the cesarean section patients. So we're excited about that. And so we hope that you take that course for the postpartum. It's mainly for nurses, and we have nursing CE for that. Anyway, but thanks for y'all tuning in today. We appreciate you listening. Don't forget to subscribe to our podcast and to leave us a review. We really appreciate when we get comments, and we've actually engaged back with several of you who've left those comments. So thank you. And you can learn more about our Critical Care Obstetrics Academy and our company at www.clinicalconceptsnob.com. And you can also follow us on our Facebook page at Clinical Concepts in Obstetrics, LinkedIn at Clinical Concepts in Obstetrics, and on Instagram at Critical Care OB. Then you could also go on our website and email us or send us a direct message and give us some suggestions for future podcasts. We really appreciate everything you do. Thank you.